What's that?
It's involuntary, but it's in the city.
The board here?
But it's involuntary. It's under FPS,
No, it's not.
It's not.
Fairly voluntary.
not, but she can do it by the pass. That's gonna.
So it's more like a halfway house?
I have no idea, that's why.
Why is this not reflecting?
And, especially as we're working with a
That's
GPO,
there, you use it then. We don't know funny stuff.
I've never, she does it.
You haven't seen the thing. Oh, I'm always in here.
Turning point at the end of the year.
Yeah.
Again, that's voluntary.
Hello, hey, how are you? I'm all right. Are you better than they used to be?
There's so many different types of, yes.
Like I was trying to make sure we didn't. Yeah, are you ready? Oh, I see, it's good to know. That's right, it's like, I got it, there's me.
That's really, it's important.
The rules around. That's what I learned. There's a second.
I apologize for. That's okay, no worries. I've experienced a lot of barriers. My daughter has experienced a lot of barriers. I have seen like a tremendous growth over the years, but when it comes to access and it comes to like meeting her where she's at and just there's a lot of barriers. I've sat and wondered to myself, what can I do? What can I do? How can I help her? And I found out about this board meeting, and I thought that I would come. That's why I'm here. Some of the barriers that my daughter faces is that she was diagnosed with type 1 diabetes when she was 16. She had already had, trauma as a child. Because of my poor decisions, and so on and so on. I got sober when she was about 10, so she's had me clean longer than she had me while I was on drugs, but she still, had lots of trauma as a child. So for the last, 10 years of my sobriety and being sober, I've been trying to make sure that she has, adequate care and things like that. When she got diagnosed with diabetes, she had already endured, she had already attempted suicide at 13. She tried to drown herself in her grandma's pool. She was experiencing severe depression, but we didn't have a name to it. We didn't know. We weren't really aware of mental health. It had a lot to do with cultural belief, spiritual beliefs, that kind of thing. But anyway, long story short, it started back when she was 13. When she was diagnosed with type 1 diabetes, she kind of just plummeted even further back. It was a lot for her to take on as a child, on top of having some of the beginning stages of mental health that were undiagnosed at that time. That opened up the door when she started failing taking care of herself with her diabetes, and I can't make her, take care of herself. At that age I could, because, I still have some say in her life. She got to 18 years old, I'm skipping a bunch of stuff, but her first interaction with mental health was, she went to Victor Agency. She was, throwing temper tantrums and kind of that rage and kind of the anger and I was seeing some of the signs. We got her connected to Victor Agency. She started seeing a therapist there. It was a great organization. However, Kendall, she would barely participate. And so that kind of showed me the first barrier was that, first of all, the therapist is kind of inconsistent, not really actively engaged, because Kendall wasn't actively engaged. And so she kind of would let her decide how much, how far we were gonna do this. So if she didn't wanna do therapy, then she wouldn't do therapy for the week. But because of the guidelines of their agency, that you had to participate in weekly therapy or else you weren't considered you didn't meet the criteria of high enough need, it wasn't intensive enough. And so, she pushed it as long as she could, but because Kendall kept pushing back and not wanting to do therapy, she eventually had to drop her as a client. She tried her best to coordinate care to step down so that she could still get her medications, but that was the first barrier because that meant that we had to switch to a whole nother organization. That meant she had to create another relationship with a whole new psychiatrist, a whole new team, a whole new, all these different things. And getting her to appointments is another huge barrier. Part of her mental health is that she can't handle a whole bunch of information at one time. She shuts down, she gets overwhelmed. It's too much. The paperwork, the assessments, the appointment after appointment after appointment, it's too much for her. And as much as, and so the next thing was that she turned 18. So boom, we all know what happens when they turn 18. They have the autonomy to do, whatever. If they want to trash their bodies, they can trash their bodies. If they want to not go to appointments, they don't have to. But being that she was able to make these decisions as an adult now with mental health that was undiagnosed, now she's not taking care of her diabetes. And so now her diabetes is unmanaged and she's in the hospital 3, 4, 5 times a year in the ICU with ketoacidosis, and her mental health and her diabetes and her past trauma and all of it, it's just all affecting each other. So now we're experiencing barriers where she is and now we've introduced substance use now. So that's another thing that she's doing in her life, what she has the choice to make. That's also affecting everything else as well. Some of the barriers that we're facing now is that she is too high, she scores too high to get just medication because she refuses to do therapy because she's done it so many times before and it hasn't worked for her. She doesn't feel like it'll work. So fine, if you're willing to take medicine, let's go get you some medication. But she scores too high to get regular care from a clinic psychiatrist, like at Dignity, where that's her provider. But then for the higher, the FSP programs and the higher level care, she has to participate in all these different things. It's a requirement. And I don't know who writes these policies or whatever, but like if she doesn't do the things that are required for the higher level care, then they would have to step her down. You know what I mean? So she's kind of in this limbo to where like we just need her to be able to, like, somebody to meet her where she's at to be able to give her the medication she needs. Sure, she can get it from her primary care doctor for a little while. A lot of them aren't comfortable with doing that, but so a lot of the another one of the barriers is like to get engaged in these services. Like she's low income and she has to be able to keep her Medi-Cal for her type 1 diabetes and all the other things, right? When she goes to fill out Medi-Cal, as I said before, filling out paperwork for Kendall is beyond, like, she will fill out 3 sentences and I'm overwhelmed, I can't do it, and shut down. Doesn't want anything else to do with it, don't talk to her. And so that's where mom comes in. Mom comes in and I'm potentially saying, I'm really acting as case manager to her because she can't seem to process this information for herself. Not is it just one paperwork, but it's like multiple paperworks. And I thank God that it's on the website now where we can kind of do it online, and that made it a lot easier and kind of took away some of the barrier from it. But it's not just paperwork for Medi-Cal, then it's paperwork for CalFresh, then it's paperwork for if she were to get with a new mental health provider, then they got paperwork and assessments and all these different things. And it's just like barrier after barrier after barrier after barrier. And these are just some of the things that, and as a mom, I can't even go in and help her fill out paperwork without an authorized representative form for each and every single one of the different places that she needs help from. We just went through this with her Medi-Cal where it got cut off because she doesn't open her mail. She doesn't open her mail. She's not even at an address long enough to receive the mail to open it and then to know what's in the paperwork. You know what I mean? And so it's just like, it's one barrier after another. And I work a full-time job and thank God I work with mental health and I work in the field. So I know kind of what's expected and those kinds of things, and I can help her. And I know, I know where to go and what to do and how to connect with her resources. But I think to myself, and a lot of the clients that we serve struggle with the same kind of issues of like, they're paranoid. They don't want to fill out all of these paperworks and signatures, and they want to know, they think we're stealing their organs. why do you want me to sign another paper? And let alone do I have to sign it, all these papers for all these different things, but then I have to do it every single year for every single agency. And it's a huge barrier. And the case managers, bless their hearts, they work as closely with them as they can. And, you know, hey, let's go get a cup of coffee and try to ease some of that anxiety around it. But, you know, and then you get case managers every other week because we can't keep enough people employed because we don't pay enough for them. You know, I think one of the peer positions is like $21 an hour. And we all know what economy we're living in right now. The office assistants get $18 an hour. It's less than they make at McDonald's. It's just like, it's so hard to keep. We have great employees that go above and beyond and want to do the extra work for these clients that they have learned and grown to trust, but we can't keep them because we don't pay them enough and they can go somewhere else and make more money. I'm sure you guys have heard this before, but I just wanted to, I think that I have a perspective from working in the field and also from being a mother of a child who's dealing with this and having to be her case manager because of the barriers that we're facing with all of these different agencies. I even have some staff members that are donating blood, donating plasma just to be able to put gas in their car to come to work. And like, that's how severe it is right now. In the field, and I know, I think it's the same issue with, you know, a lot of nonprofit organizations or whatever. It seems like it's always understaffed, underpaid, and these are some of the most vulnerable population that need us to be able to provide the support. And like, we have all these great things surrounded to help these clients, but it's not sustainable for the employees that work there, you know? And so I kind of have both perspectives. Let me see, I don't know if there's any other. I asked my daughter if she had any input. I don't know if she responded to me yet, but that's kind of touching on some of the things that some of the struggles that we've dealt with. And I just want to know as a mom, like, what do I do to make a change, or how can I and you guys probably can't answer that question, but like, how do I make change? How do I help? And it's not just from my daughter, but all the ones like my daughter who have, there's so many of them. There's so many faces, there's so many names, there's so many of them. And they're just struggling. They're struggling and it's not easy, you know, and I think like more things to get, like, take down some of the barriers that like they're experiencing, make it as easy, make it easier to access care, you know, less complicated, less, just easier access, you know, they need access.
Well, first of all, thank you so much for being here.
Thank you for having me.
It's wonderful when someone comes in with a perspective to help us understand what they're going through,
Thank you.
and really to be brave to share your story.
Thank you.
Thank you very much.
Thank you for having me. And I don't even know if this is all appropriate, but I just, you know, wanted to just like lay it out and, you know, I don't know what to do. I don't know how to make change, but I know that we need change.
I wanted to share with you, there are some
Thank you.
suggestions for resources in the chat, and I can share those with you at the end of the meeting, so that you have. access to them.
Absolutely. Thank you so much.
Okay. The first item of business that we have is approval of the agenda. Has everyone had a chance to look at the agenda? Do I have a motion?
So moved.
Do we have a second?
I'll second it.
All in favor, say aye.
Aye.
Any opposed? Any abstentions? Okay, the agenda is approved. The next item that we have is the minutes from September 4th. Did everyone have a chance to look at those?
Yes.
Do we have a motion?
A motion.
And
I'll
thank you.
second.
Thank you, Chris. Melanie? All in favor?
Aye.
Any opposed? Any
Abstain.
abstained? You're abstaining? Okay. Thank you. The next item we have is member announcements. Does anyone have any member announcements?
I was going to just point out that Tooele County has an opioid coalition. And the next meeting will be at noon. I don't know where yet. I didn't get the location, but I believe it's going to be somewhere at 137 North Cottonwood, between noon and 1:30. With us becoming a behavioral health board next year with a focus on substance use disorders and addiction, and with the fentanyl and opioid crisis, I think the educational thing, one can make that.
Do you know if there's a virtual option on that?
They were working on it, but I don't know if
Okay.
if that's in place yet.
Okay. And what was the date of that?
It is October 25th at noon to from 12 to 1:30.
And where?
I don't have the location yet because I only got the email with the date and time,
Perfect.
but I believe it'll be probably one of the rooms in 137 North Cottonwood. Last time they used two of the rooms, it was the Thompson room, I forget what the other, with the divider in between. Maybe you could probably help me out with what those rooms are.
Yeah.
A lot of different community providers participate in that. So just throwing that out there.
Maria, I don't know if this is a comment or more of a question, and feel free to move it anywhere if you want. So one of the things I'm hearing in some of the peer groups that I facilitate is ketamine. And so we know ketamine has an appropriate usage in mental health. Unfortunately, though, ketamine is being used like opioids, it's being abused, and it is having detrimental effects for people who suffer from schizophrenia, somewhat similar to marijuana from what I understand. So I was just curious if we as a board should have some education or something related to ketamine use and what's out there, and because it's not just opioids, it's ketamine as
We
well.
have methamphetamine and a whole slew of things out there. It's just that there's this one meeting for the opioid issue.
Yeah, and I'm sure they address this too. And it's just, there's gonna be more publicity around that because there's a lot of kids using it now too. And so what's happening is it's exacerbating the issue of schizophrenia. So just something, don't know where it fits, but
No.
I am hearing more about that.
And Carly, we kind of talked about how next year we'll see more about addiction. So maybe we can write into some of our meetings, having some presentations in that space.
Yeah, we would love to assist to bringing some presentations here around substance use disorders, around, whatever topics really come to the top for this board of interest. We're looking forward to integrating more of the substance use disorder, topics into this space as you become a behavioral health board.
Thanks, yeah, and thank you. It'd be great to attend that.
No, thank you for sharing that. There was something that came across at work for American Foundation for Suicide Prevention. They have an Out of Darkness walk. It's going to be October 19th in Sacramento. If anyone's interested, I'll make sure to share that information with Christina to distribute out to the board.
What day was that again?
It's October 19th.
Thank you.
I'll send you all the information. Anyone else have member announcements? Okay. We do not have a chair report tonight from Jonathan unless he sent you something, Christina? No. Okay. And do we have any correspondence?
No.
Oh, I thought we had that email that you had.
Did you decide that was considered correspondence?
Oh,
Because I don't know how.
Jonathan, I think, was looking into that to see if it was.
Oh, okay.
Okay. Now we have Tony to do a presentation for us.
Thank you. I appreciate the opportunity to provide a presentation to the board regarding the local children's system of care. We're just going to give Christina just a sec to pull it up. I'm Tony Kildare. I'm the branch director for the Child, Youth, and Family branch. Part of my responsibilities are to oversee the Children's Behavioral Health Services. So, as you can see, we've laid the presentation out in our trademark agency colors. We're using some of our new branding. So again, I'm the branch director for the Child, Youth, and Family branch. Can we go forward? So one of the things I want to talk about with our local system of care is the behavioral health works with many partners, right? So behavioral health in the children's system, some of the most important partners for behavioral health are child welfare and probation, but we work with a number of different partners, including the Office of Education, all of the local education agencies, the Alta California Regional Center, the Court Appointed Special Advocates Program, First 5 YOLO, and Yoshidiki Winton Nation, through the auspices of the interagency leadership team that was created with regard as a result of AB 2083. So AB 2083 required all of the counties to submit a plan explaining how all of these different children's systems were going to coordinate services and work collaboratively together. We've been working locally to, some of the priorities are around information sharing and to work on developing some collaborative relationships with the Yoshidiki Winton Nation, right? So I just want to point out that our system of care, there is a behavioral health based system of care, right, with our internal services and contracted providers, but we also work as a network with all of the different child service systems.
Tony, do you want questions at the end?
You can, no, please, the more of you and less of me is a great thing.
Be careful, tell me that.
I mean, my presentation style is like I would prefer for it to be more interactive, right? So this will work perfectly fine for me.
I just have a question.
Absolutely.
So CCS,
Yes.
where do they fit into this, if at all?
California Children's Services, that is a medical program, and so they do fit in the sense that they are actually part of the branch that I oversee. So the Child, Youth, and Family branch is Child Welfare Services, Children's Behavioral Health, and California Children's Services. California Children's Services primarily serves medically fragile children, and so if there's overlap with behavioral health, then we would work with the families. One of the pieces that we recently have been doing with behavioral health is that our internal team is providing support to California Children's Services for the parents, right? So what has come up is that sometimes some of the parents are having some difficulties or challenges with kind of what's happening, and they're right over there, right? We have our medical therapy unit, and our team is over here in 137 North Cottonwood. And so because of the proximity, we're able to go over and provide some support when it's necessary, right? You know, when we have a determination that there are some behavioral health related challenges. A lot of times too, because of our relationships with Alta California Regional Center, we can help navigate some of those issues or help some of the families navigate some of those issues. So we're not necessarily getting formally involved with the families unless they have a behavioral health need for their children, right? But we're providing collateral support because they're within our branch. Okay. Is that what you're looking for, or is, okay, all right. Okay, any other questions about the interagency leadership team? Okay, next slide, please. Okay, so these are all of the local behavioral health programs. We have our internal children's mental health program. We have what are called community-based services. We formerly used to call them EPSDT services, and they are still provided through the early periodic screening, diagnostic, and treatment benefit of Medi-Cal. We just changed the name from EPSDT to community-based services to more accurately reflect the array of services. So these are kind of the base level of specialty mental health services that children and youth would be eligible to receive. And they can be provided anywhere in the community. So we have services that can be provided in the homes or in school settings if it's appropriate, in clinic-based settings, wherever. So we want to make sure that we're describing where the services are being provided. There's full service partnership services, wraparound services, which are similar to full service partnership services. They're both team-based models where you would have a therapist and a case manager and perhaps a peer partner. We have juvenile justice behavioral health services that are primarily focused for justice-involved youth. We have a K-12 school partnership program, which is a collaborative partnership between HHSA, the Office of Education, and all 5 school districts. We have a college partnership program, which is a collaboration between HHSA and Woodland Community College. We provide services for youth through short-term residential therapeutic programs. It's not just a specific program. These are programs that are located all throughout the state. We have a specific relationship with a specific provider, and we can get into that a little bit later. The Family Urgent Response System is something that I wanted to talk about, even though it's not necessarily a behavioral health-based program. There are behavioral health services can be provided through PERS. And then, of course, as I talked about before, the Early Diagnostic and Preventative Treatment Program. It's the EDAP program.
Looks like Nikki has a question.
Oh, good. Hi, Nikki.
Sorry, I can't be with you tonight. I'm recovering from a sinus infection, but I still have a temperature. So, at any rate, I wanted to ask if the college partnership also included UC Davis.
The College Partnership Program does not currently include UC Davis. It's a particular relationship that we have with Woodland Community College with a contract and services that are provided through CommuniCare OLA.
Ah, okay.
We do not have a relationship like that with UC Davis at this time. We do have a relationship with UC Davis in the Early Diagnostic and Preventive Treatment Program, the EDAPT program.
Okay.
Which is a program that's intended to treat first episode psychosis.
All right.
So it's
What is the age range for the EDAP program?
I believe.
I have some people that are mental health court or other adults that go into EDAP. So I think maybe low 20s, but
Mid-20s, I think, and actually there's gonna be some state guidance changes with Prop 1, actually. It's gonna mandate early intervention program, early psychosis program. But actually, I think the recommendation from UC Davis is to extend the age range for who's eligible quite far, actually. So I think I don't know that.
If I remember correctly, and it's been a while since I've been in the EDAP program because I apologize, it was in a different branch for a while and it's now just back. I believe it was 14 to 26, right?
Sounds about right.
I think it was 4. I believe, I can get back to you on that and be more specific.
Sam's saying maybe 13 to 30.
13 to 30, okay, all right, okay.
But anyway, this was just a recent topic of conversation at our DHCS Prop 1 implementation work group. Apparently there's some consensus around really expanding that age range because of just some of how first episode psychosis can sort of come to light, how long it can take for some people to come. So there's some recommendation around expanding that, and this goes far beyond sort of a youth system of care. So it's an interesting crossover with adult services.
I mean, the feedback I've heard is a very good program.
Their program is excellent, and they're like the center of excellence for DHCS for this. So yeah, we should be proud to have that here locally for us. Yeah.
I just had a question on the K through 12 school partnerships. Is there any training for like teachers really to help understand what early signs are and when they need to make referrals? Is there anything like that?
So what I'm going to explain. So when we get to an.
Oh, you're going to get to it. Okay, I can pause.
I'll give you a preview.
I'm okay. I can wait. Go ahead.
Just help me
It's
remember.
coming.
Help me remember to adjust.
Yes, I
it.
will.
Okay, all right.
Sorry, can I one more, I have a question.
Oh no, please. Yes.
So for neurodivergent, so kids who have dual diagnosis, maybe they have a neurodivergent disorder and they have maybe a mental health disorder. Is the Mind Institute ever brought in? Like we have a partnership with them?
We don't have a specific partnership with the Mind Institute. I think that if on a case-by-case basis, if something were to come up, we could connect with the Mind Institute when it's appropriate. Again, I believe that, are you referring to like perhaps like a regional center client?
Yeah, what I'm hearing, more and more kids are being diagnosed even in high school, later in their childhood. And then parents are struggling because they have dual diagnoses that require different services.
So when we, again, because of our partnership with the regional center, we would work with the service coordinators from the regional center about the most appropriate route, to take to serve the child, right? Okay. So it could involve the Mind Institute, but we don't necessarily have a contractual relationship with the Mind Institute.
So it would be referral appropriateness.
It would be based on the appropriateness of the referral, and my experience with it, and I not necessarily here in Yolo County, but my experience from Pryor County is we would work through the regional center to access services through the Mind Institute.
And then do families have to be on Medi-Cal for that, or if you have families with private insurance that live in the county, can they also reach out, or are they kind of on their own because they have their own insurance?
For accessing services through the Mind Institute?
Through the regional center, I'm sure.
So regional center services, I mean, I can't, that's a different hat for an organization I don't work for. But regional center services are services that youth who are diagnosed with a developmental disability with an onset prior to the age of 18 are entitled to, and they're for life, regardless of, it's an entitlement program through the Lanterman Act. And so it doesn't matter what type of insurance.
That's what I read, that I wasn't sure if I was interpreting it correctly, so thank you.
No, 100%. And then we'll talk a little bit about the regional center a little bit later too. Yeah. So these are their referrals come to us through many different pathways, right? So we have our 24/7 access and crisis line, which I believe you have heard about before. And that is a number that a client can call or a parent in the situation with a child, and self-refer for services. And they'll do a little bit of a triage assessment and make a determination about where a child is likely to be served. We have relationships with both of our managed care plans in Yolo County, with Partnership Health Plan and with Kaiser Permanente. And kind of the way that referrals are sorted out is that youth who have mild to moderate symptomatology are primarily served by the managed care plans, and then youth who have more serious etiology are served by the mental health plan. Now, CalAIM created like a no wrong door type of, it's actually called no wrong door, where there is a mechanism where a managed care plan could serve a youth who meets criteria for specialty mental health services if it's in their child's best interest, and everybody agrees to that. And the same, we can serve youth who might not necessarily meet criteria for specialty mental health services if it makes sense, right? But for the most part, the idea is that the managed care plans work with the mild to moderate population, and we work with the population that has more serious symptoms. The managed care plan also refers clients back and forth to us, right? So even though with our access and crisis line, they'll kind of do a little bit of a preliminary referral to which system they think is appropriate. Managed care has contact with clients, either they're routed to them or they come to them in various means, and they conduct a more thorough assessment, and they will identify sometimes youth who were more appropriately served by our system. And so that's another way that we receive service, and it's a two-way system. We do the same thing when we're working with a child. If we identify that the child will probably be better served by the managed care plan, then we can refer to them as well. Child welfare services and probation refer directly to behavioral health. So in Yolo County, for quite some time now, all children who enter foster care are automatically referred to behavioral health for an assessment. Previously, we had a system where there was like a screening tool, and some children were getting referred and some children weren't. But it makes more sense to just assess all of the children and to provide services if they're necessary. We're pretty fortunate to be an integrated system of care. In many counties, child welfare and behavioral health don't necessarily get along with each other. I mean, they all partner. I mean, all 58 counties partner, but individual results may vary, as they say, right? But we're very fortunate that, you know, I'm kind of the boss of both systems. And, you know, we can make them be nice to each other, right? And so in our system, when children enter foster care and they're referred to behavioral health, sometimes we have children who are not placed in Yolo County, so they wouldn't be receiving services through our behavioral health system. And that can make things much more complicated, right? There's a process called presumptive transfer where we send referrals to the county that's receiving the foster youth. And then that mental health plan is supposed to make sure that the youth receive services. And our internal mental health team actively tracks that, right? So our internal mental health team is the one who sends the referrals over on behalf of child welfare, and then they remain engaged with the other mental health plan and make sure that they get services, right? And so that's something that's a real benefit for our local foster youth, because that is not a system that is easy to navigate, and in many other counties, that's left to child welfare workers or probation officers. And then the schools and college are another source of referrals, right? So because of our partnerships with the school districts and with the Woodland Community College, students who come into, students that the schools are concerned about for one reason or another can be referred to services through those programs.
So is it only Woodland Community College? Because I know like WSAC partners with City College.
Right now, our college partnership program is limited specifically to Woodland Community College. Okay, so I want to be clear here that the slides are kind of busy. They can contain a lot of information. And the idea really isn't for me to read all of this stuff to you, right? But it's so that later on you will receive a copy of the presentation and really go on to provide a level of detail so that if you want to refer back and you would have this information available to you. So we have an internal children's mental health team. It's a small but mighty team. It's very small, right? And we have a manager and a supervisor and a few therapists who work in different settings. So we provide support to the Multidisciplinary Interview Center, which works with children who are suspected to be a victim of a criminal act of child abuse. And that's a multidisciplinary effort between the DA's office, law enforcement, behavioral health, and child welfare, and the local law enforcement agencies. So we have one staff who's permanently stationed out at the NDIC. We also have staff that provide support to the juvenile detention facility, and we have staff that are located in our office. The staff that are located in our office will see their clients either in our office or out in the community through community-based services, but they're very helpful for us to have, like in the case if we have like some significant child welfare challenges or something like that they're happening. The other duty of the children's mental health team is to provide access and linkage, right? So when a call comes into the 24/7 access and crisis line that gets referred to us, then that team kind of works on determining what the level of care is likely to be and then routing the client to the appropriate service, right? So we have contracted services, and so they'll make some decisions about whether or not we're going to serve them internally or if we're going to send them out to one of our contracted private partners and what level of care that ought to be, what level of care it's likely to be. The contractor who works with the children will kind of make a final determination if that child's appropriate for that level of care. But that's what a big part of what our internal team does is like kind of routing referrals to where they need to go. This on the right-hand side here, it talks about the community-based services program and what early periodic screening, diagnostic, and treatment is as a Medi-Cal benefit. And what we do is we provide specialty mental health services to children and youth ages 0 to 20 under EPSDT. And I want to make it really clear that there is this like overlap between the children's system of care and the adult system of care, right? We can serve children and youth up to age to their 21st birthday. And then they would be served by the adult system. But the adult system can also serve youth that are, at age 18, right? And so there's a little bit of not a little bit, there is coordination between the children's system and the adult system about which system should be caring for some of these kids, right? Typically, when we have youth who become adults, sometimes those youth don't want to be served in the children's system anymore, right? They feel, they're adults and they want to be served in the adult system. Sometimes it's more appropriate to serve them in the children's system. And so other times it's just not appropriate, right? They have, their symptomatology may just be too severe, that it really exceeds the scope of what the children's system is capable of. And the adult system may have more ability to serve those individuals. So we have our internal team that provides community-based services, and we have contracted providers that provide these community-based services. So currently we have 3 different contracts with CommuniCare Olay, Stanford Sierra Youth and Family, and Victor Community Support Services. I also glossed over a little bit on the left-hand side here, some of the other things that our internal team does, right? I don't want to minimize what they do, right? So they provide direct services, they support the MDIC, they support the JDF, they do access and linkage. They also coordinate discharges from hospitalization. They provide group services. They participate in multidisciplinary team meetings. They coordinate child and family team meetings for both behavioral health and child welfare. And they attend SARB hearings. And there's another piece here around, we don't need to get into the weeds about this, but we have a requirement to have a qualified individual for any youth that we want, that we are referring to a short-term residential therapeutic program. We can talk about that a little bit later. Let me check in with you. Like in terms of detail, do we want more or less for each slide? I think we're good. Okay, let's go.
Yeah.
I just have a question. So we have the youth that we're serving up until they're below 21. So like, what's an example of somebody that's like 18? Why would they just rather go into the adult?
Sometimes they do. Sometimes they do.
But why would they?
Yeah,
Oh,
like,
why
what's an
would they?
example? Like we had
Yeah.
somebody here earlier talk about their 19-year-old child.
Yeah.
Like, would that be, how would a person like that access a system like this?
I want to make it really clear, like the children's system of care is really designed to serve children,
Yeah.
right? And so these are, even though they may have significant symptomatology, it's like significant symptomatology for a child, right? What we sometimes experience are youth as they're developing and their symptomatology becomes more severe and their behavior just becomes more severe. And it may just exceed the ability of the children's providers to actually serve that particular individual. Sometimes it's like, if it's like a client-based setting, it may not be a good idea to have someone who has the kind of symptomatology come into a place that serves children, right? It generally tends to be individuals who have much more significant needs and potentially like aggressive behavior and that type of situation. The adult system is better equipped to work with those individuals and to address their specific needs than the children's system. And so it's really it's a decision that's made in collaboration with the client and with both systems, right? It's not something that comes up very often, right? When we work with youth, and we typically work with youth up until their 21st birthday, if it's appropriate. It's on a case-by-case basis when we have a youth who's exhibiting some like really extreme symptomatology, that we would start reaching out to the adult system and saying, hey, we think it's probably a better idea for you to serve this. And it can go both ways, right? We can have the adult system who may do an assessment with someone who's 18 and say, hey, we think this youth would be better served in the children's system.
Care. Yeah.
Right? Yeah.
Yeah, so I mean, I think and this is something that actually Tony and I worked on a lot when he got here.
100%, yeah.
Because, and I'll say every county handles this a little bit differently. I think, right, while you have the flexibility to serve youth, through the age, as Tony was talking about, in some systems that there's maybe been more hard lines in between those services. And so for us, we really felt like it was important to have a lot of flexibility there to meet the individual needs of the client and family. And I think where we have found, I just wanted to add, I think where we have found the transition to the adult system of care helpful has also been as it relates to individuals who have serious mental illness and who are going to need long-term supports. And so sometimes it's around sort of timing and pacing around that transition so that they can establish with a team or a provider or enter a level of care, like maybe an adult full service partnership, right? Where they're going to then end up in a supported housing arrangement and things like that. And so I think all of those nuances are important in making that decision. And I think we've also had experiences where maybe someone has started to be served in one system of care and have found that maybe that wasn't the right fit at the time for whatever reason, And I think the family supports and engagement of family and services is also sort of a big piece, right? In the children's system of care, there's not a lot of just treating someone alone by themselves, right? And so I think all of those dynamics are all pieces to consider.
I agree with 100% with everything Carlene said. I think also we get into situations like maybe the client needs like more frequent contact, right?
Yeah.
And that's pretty common for children's systems to have more frequent contact with a client than in an adult system. There's also another layer to consider, right? Because we have our children's system, we have our adult system, and then you have like transitional age youth services, right? And so those are services for, they're full service partnership services for youth that are 16 to 25, right? And so then there's another layer of out there, right? And these are for youth who have more serious symptoms, right? In those services, but the idea really is that those youth are better served in a system that's working with more similar aged youth, right? Where you have potentially someone who may be served for a long time, right? And it allows them to kind of work with providers that are more experienced with working with that population, but also like to have some group settings with other individuals that are that age. It can be difficult for someone who's maybe like 19 to be in a group with someone who's maybe in their 50s, right? So you want to try to put them in those types of settings as well.
Thank you.
Yeah, no problem.
The county used to have a TAY team, I believe, before you arrived, and now those services are contracted out.
Well, it's funny you should say that.
So the question, how is that working? Are the community members getting better service contracted out, or was it better when we had the internal TAY team?
I think that would be a question that would be better answered by clients themselves, right? I mean, it's hard to say. You're going to have, I think, people on either side of this, right? So,
sorry, what's the TAY team? Sorry.
Transition age youth.
Transition age youth. Right? We serve with. There's a transitional age youth team that serves full service partnership clients who are ages 16 to 25. So when we had the internal TAY team, they did receive great care, right? I mean, obviously. And we were able to serve a certain number of people, right? However, we weren't able to provide some of the aspects of the program that are required for full service partnerships, right? So if you're in a full service partnership, you're supposed to be able to, at any time of the day or night, pick up the phone and call someone who is familiar with your case, right? To provide you with support, regardless of what time of the day or night it is, right? And we weren't able to do that as a county system. Right, as a county-based system, we're not able to do that because of different rules with our employee unions that we're not allowing for us to be able to do that. The other part is that, I mean, county employees are expensive, right? So we can only serve a certain number of youth, right? So when we contracted out the services, we're able to serve more youth, and we're able to provide some of the services that, like having access to someone 24 hours a day that we weren't able to provide as a county-based system. Now, when you start talking about, like the quality of the services or whether or not people are receiving better treatment or better care, right? I mean, there's a bit of a value judgment that goes along with that. I think the other part too is that the county-based state team was very well established and they've been working with the clients for a long time. And you kind of have like a benefit of when you are fully established and you have clients that you've been working with, as clients rotate in and out, there's a bit of a culture there, right, around how the services are provided. Like Tay services they work like, they call it like a clubhouse model in some ways, right? Is that you try to do a lot of group activities and things like that. You try to have opportunities for the clients to interact with each other in addition to receiving all of the other treatment services. And so a new provider is going to have to get established in order to really have that continuity of care. To get to the same place that we were as a county-based program, right? And so, again, I'm very reluctant to say that the services were better there or better now, right? It's just part of the process of switching to a contracted provider that there's going to be a little bit of time for that to be operational.
I'm just asking because we shifted from internal services to contracting out for Tay, for adult. And I think one of the questions that we all would want to know is when that decision was made, you guys weren't here. So we
were, but we weren't in our current role.
We were not in our current role.
Yeah, we were here.
The decision was made, and I think long term, one of the things we need to look at is that working.
Yeah, and I'd love to chime in here. So I think that I'll just say for those who may not be aware, this was a very controversial topic. So Chris is bringing up something that has a lot of history and controversy. So I want to just call that out. A lot of sort of tension around it, I'd say internally and with partners, and certainly with some public scrutiny, right? So the decision, and to be clear, we did contract out FSP before this, but we had a portion of FSP in-house, and there was a decision made to contract out all of FSP. And I think that was probably well discussed and vetted here. Again, we were in our role, so we weren't attending the local mental health board meeting then. And I want to acknowledge our transition and youth team because they did an incredible job. They had a focused population. The work that they did was a combination of FSP and non-FSP. So I'll say that, right? So when you asked, is it apples to apples? No, because that team was serving full service partnership clients and non-full service partnership clients, which I think is actually a great model, right? It allows for flexibility. But what we currently contract out is only FSP slots. And so I think that there's not necessarily an apples to apples comparison just in general. When you ask how it's going, I'll say the transition to contracting out our full service partnership has been very challenging overall. And this isn't specific to Tay, but certainly the transition age youth clients and that program has been just as impacted as the other programs that were contracted out. When we initially contracted out FSP, there were 2 providers selected, each with 100 FSP slots, basically 100, 100, 200. We ultimately ended the contract with one of those providers because of performance issues. It was a mutual decision to end the contractual relationship, but we were having major performance issues, which we've talked about here. And then we had to ask the other provider to take on all of those other slots, which doubling your census and your program in a very short amount of time is incredibly difficult. And so we're continued to be challenged. And also just to give some background, no matter what provider's been providing contracted FSP services for the adult population, it's been challenging. And there's been community feedback and criticism, right, around service delivery. And we continue to monitor and try to address those to the best of our ability. So the transition was difficult. It was very difficult for the clients. They had well-established relationships with their providers and they had to establish with a new team. Many people fell off of services during that time. And, I can't give you exact numbers. I don't have data for what I'm sharing now. So please take what I'm saying, with a grain of salt, right? I'm not sort of sharing data here. I'm sharing more broadly. We had people who stopped engaging in services or stepped down to lower levels of care, who chose not to continue in a full service partnership because the team was changing or, whatever the situation might be. And so I sort of can't understand enough how difficult it was all around for staff and clients alike. Some of the outcomes that we've been reviewing, right, and now that we went through a rough transition period with having to end with a contractor and then shift services to a new contractor. So some of the outcomes that we've started to review, there are some concerning data metrics that tell us that some things got worse. And whether that's because of the contractor or because of the change or because of a myriad of factors, I can't say exactly why. I can say that we're paying close attention to it, that we are doing our best to implement interventions and work closely with our contractor to improve those outcomes. And these aren't specific to TAY, but your question I have to answer more broadly because there's a broader impact. What the right model for us moving forward is, I think, is a question mark right now. We do have a small FSP service provision still internally with some of our forensic programs. We've maintained that even with the contracting out. We've always contracted out our children's system of care FSP with no issues, really. I mean, minimal, I'd say, but with FSP, there was really no issues. And so the challenges we experience are somewhat unique to the adult system of care in terms of, and I think that the services are difficult, right? And these are difficult services to provide. So there are a lot of opinions about what model we should be using, and I think my opinion is that probably a balance of some internal service delivery and external contracted services is probably the right balance. Tony mentioned the requirements under a full service partnership, which are that someone known to the client be available to them 24/7. So how most counties accomplish this is through a system of standby and callback, right? We don't have standby and callback as a requirement for our clinical staff in their class specification. That's a union challenge for us. We also have a very small team clinically. And so while I think there are many people who would say, I would volunteer to do standby and callback, without having a sustainable model for that, it becomes very difficult, right, to maintain. And so that is just one piece, right? I know that the decisions were driven by finances and budget, and there was, there was a lot that sort of went in. And again, I wasn't in this role. We didn't make the decision. Tony and I had to try to help
It was a very challenging
navigate the transition. And
When was the transition?
2019, 2020 maybe?
No, it was after I got here. So I got here in 2020.
Oh, that's right.
I believe it was
2020 to 2021. Yeah.
So right, the pandemic.
right as the pandemic.
Absolutely, right. Talk
Absolutely.
about a perfect storm.
Yeah.
And, and the challenge, how challenging it was administratively pales in comparison to the challenges that the clients experience and the staff impacted experience. I don't want to suggest that this was, woe is Tony and I, right? But just that this was difficult all around. And so I think that there's a lot of opportunity for us right now and ahead to evaluate our programs, to use data to help us drive our decisions, and to maybe come back to some point of balance around what the future and what the needs are. And as we'll hear a little bit later, when I get to talk to you a little bit about MHSA, so much of this is hinging on our MHSA funding, which is really challenged, and it will be especially challenged in the coming years. And so we can't have those conversations separately, right? We can talk about the gold standard and what we would ideally want, and then we have to talk in realities about what the funding available to us allows us to do, and finding a balance there. So it's a complicated topic. Thank you so much for this. But you knew you were asking a difficult question. I just
was just trying to focus on the TAFE part.
I know, but you can't
It's
really,
hard-
right?
it's hard to
Without the larger.
It's hard to unpack it.
And you know the history, and so
I know a lot
it's
of
not
the
fair.
history.
It's not fair to. We can't just say things are going great or things are going terrible, because neither of those are true, right? Some things have gone well, and some things have not gone
It's a mixed
well.
bag, but it just,
Yeah.
one of the things we here need to do as the board is to be informed, understand what's happening and what's happening going forward,
Yeah.
So I nicked a nerve.
No, it's okay, but I feel like you're one who knows the background and not a lot of other people do. And so I don't want to be having sort of like a secret conversation across the room. And so I would prefer to be.
They all need to, everyone here needs to understand.
I prefer transparency, right? And so I appreciate you letting me get on a little soapbox about it for a little bit, but I feel like peeling back the curtain a little bit and talking about what this was like and what we're seeing in terms of the outcomes. There are some concerning data points, right, around some increases in hospitalizations and things like that we are looking at really closely. Some of that might not be only specific to TAY, but certainly is impacting that TAY population. And I think there was a real sense of community that was lost in the process. And I don't know, and we want to regain
I will
that.
say that changing the contract from the 2 providers to the 1, we saw a different quality criminal justice system with those individuals getting the services, and an improvement when that happened. So I think that was an evaluation, but I think that again, everyone here needs to understand the big picture, what we're talking about on that. I was just trying to focus on the tape because it came up here and I was curious.
It'd also be interesting to know if that transition would have been less difficult if we weren't in a pandemic, because everything was just disconnected.
Well, there's some, I mean, for our teams became a lifeline for folks during the pandemic, you know, and so I think that I think this would have been challenging no matter what.
Right.
And I think there would have been unintended negative impacts no matter what. But I think that those things were exacerbated because of the nature of what we were, like the dynamic in which we were functioning, right? Where a lot of things were still closed and for some, like really the only, the most connection they had was getting food bags delivered and getting the services that their team was providing, you know, so I think it especially, it made it an especially challenging transition for sure.
All that to say that the decision to contract the services out was very controversial. And again, just to be fair, I certainly don't want to minimize the excellent services that were provided internally. I think in just trying to answer the question diplomatically, it's like, it's too soon to tell with the contracted services, whether or not they're going to be able to provide that same level of care that they were receiving when they were being provided services internally.
Is there an assessment period where you would say, okay, let's see if this is working and reassess?
Well, here's the thing that I think it becomes challenging, right? And we're a little off topic, and I'll try to be concise. The TAY FSP population in particular, we've had this history of, we had an internal team and we contracted it out, and we had an internal team and we contracted it out, right? And every time we make that transition is incredibly difficult, right? And so you get to, and again, my boss is the mental health director, so she may disagree with what I'm about to say, but probably not, right? You get to a point where you're like, maybe this isn't working.
I'm just used to it being
Maybe this isn't working as well as we would like it to, right? But then we have to make a decision about, do we try to support the system and get it to work the way we want it to do? Or do we make these clients go through yet another difficult transition, right? You know, and I think that is sort of the dilemma.
Yeah, that makes sense.
Yeah. I'm gonna go, go ahead.
I'm not gonna add anything about that.
So I'm not gonna ask anything about TAY.
No, but it is somewhat related in the sense we talk about partnerships, and it's been helpful to be on the quarterly call. I think it's quarterly to quality, which is
Oh, the
helpful.
QIC.
But what's amazing is how many partnerships the county has.
Yes,
Okay, so you have contracted service act, you have,
right.
and then you have all these other partners, managed care, everything. So I'm just curious, how do you feel like we feel like have a good understanding of all of the services that our children in this community and our communities are receiving? And that might be too broad of a question, but I'm just trying to think, how do we put all these pieces together? Because there's a lot of partners.
So I think that I have full confidence that my internal team does understand how these pieces fit together, right? And I also believe that like no one of us can understand how every single thing works, right? I mean, it's just it's it's a lot. So we're very fortunate to have staff who have a lot of experience working in the children's system. And I mean, like myself, right? But I mean, I'm not trying to be, but it's like, I've worked with the regional center, right? I've worked with regional center providers. I've worked in child welfare. I've worked in the district attorney's office in the victim witness services program. I've worked in behavioral health, right? I've worked very closely with probation all throughout my entire career, right? And so along the way, you learn how all of the other systems work. I feel like I can speak somewhat competently to how the regional system center works. And I feel like I can speak with some authority about how probation works, right? But obviously, like, we can't answer every single question, right? So it's like, I do feel like we can, but it is hard to distill it down for like, an audience, right? But we'll do our best.
Maybe a question for that about metrics. I know that was a big topic for us as
Sure.
with metrics, and I won't ask you those now, but
Sure.
I do think that's a big piece of it is, are we really tracking the right metrics?
We-
You mentioned hospitalizations are up, all those things. So I just think, and maybe you're probably going to talk about that, but it just keeps coming to mind with all these partners. The only way we can really monitor is to have some metrics that make sense. So,
I completely agree with you. I mean, on the child welfare side, we're very fortunate that state has put together something that really is a robust data collecting mechanism, and that allows us to really actively, like, we can say, oh, wait, hold on, we see something is like, we're having some problems in this area, we really need to focus on it, and that's something we still need to build out in behavioral health, right? So I'm well with you.
because whether it's TAY or whether it's,
Right.
there's a gap, there's
Yes.
some metrics that are going to.
They're 100%.
Right, okay.
Yeah, we agree. Yeah, and we talked at a previous meeting about some of the challenges with that data, and especially with all of our providers being in the different electronic health record systems. And that's something we're actively working to address as well. But
And
I'll let my
different-
boss talk about that at a later date.
And then different counties, because our two biggest providers are not in yellow, right? UC Davis and Sutter, Children's Services, they're not in our county, so
Oh, for medical services?
for
Yeah.
children. And so it also makes it even more complicated.
Right.
As well, so.
So, I mean, we do have, we'll get to, I want to try to go through the slides a little bit quicker because I know you guys want to go home at some point.
Yeah.
And I still had a lot, so, and I'm happy to hang out afterwards if anyone has any other more detailed questions. I can talk all day. So we have what we call intensive services for children and youth. So the wraparound and full service partnership are both very similar models, where it's a more intensive than just a child having a therapist, right? It's a team that actively works with the child and family, and that provides a therapist, a case manager, a lot of times a peer partner, and then we can also provide funding directly to the family when they have some specific needs. We have different contracted providers to wrap around. We have Communicare Olay and Stanford Sierra Youth and Families. With our full service partnership, we have one program that provides services from 0 to 20. That's Victor Community Support Services. We expanded, it used to be 0 to 15. We expanded the range from 0 to 20 because what we were discovering was that it was a difficult transition from the kids when they were 15 and then they had to go to a different program when they were 16. And sometimes they were better served by just remaining in the program where they already had the relationships.
And I just want to say those age ranges are determined by the Department of Healthcare Services
Right.
through the Mental Health Services Act. So
Right.
those like 0 to 15, 16 to 25, 26 and older we're not ever are doing. And that's how the data is tracked though. So I will
Yes.
say that's the thing that gets tricky with FSP data is that
Victor is technically serving some TAY youth.
it's age-based
Right.
data.
Yeah.
So while we have maybe a specific TAY program within Hope Cooperative, our children's provider is also serving youth who would be categorized as transition age youth under the FSP age ranges. So that is complicated and that's not something we have control over. That's a state requirement.
Can I ask you a quick question? Back on wraparound, that used to only be available through child welfare and probation. Now it's broadly available?
No, so it is still in Yolo County, it is still currently only available for child welfare dependents and boards of the court. Full service partnerships or services are any individual in the county is eligible to receive full service partnership services, right? Technically, we could serve non-Medi-Cal beneficiaries as well because it's funded through the Mental Health Services Act. However, the Department of Healthcare Services is currently working on a proposal to make wraparound services Medi-Cal benefit. All right, and so there's a lot to unpack there with the funding and how it's going to work, right? And they're kind of going back and forth with the California Behavioral Health Directors Association, and they're trying to sort things out. So in a future meeting, you may be hearing me say, oh, we can provide wraparound services to any Medi-Cal beneficiary if they meet criteria.
Yes, presently wraparound is optional for foster care entities in the state, and there are some counties that don't have wrap at all.
Yeah.
And so it is currently optional, but Tony's right, and actually the effort is to include that as a benefit and to roll it out as actually part of Prop 1 implementation as well. And so specifically high fidelity wraparound, which is wraparound that meets a certain measure of fidelity in terms of evidence-based practice.
Okay, and then the last intensive service is therapeutic behavioral services. Therapeutic behavioral services are intensive services that can be provided to a youth to address a specific behavioral issue. We can provide, they can be very extensive services. We could provide services like up to 23 hours a day by statute, right? It's not something that's very common that would occur that way. And the idea is that TBS is provided as sort of an adjunct to an existing specialty mental health service. So they'd be receiving services through one of the other programs, whether it's community-based services or MSP or whatever. And the therapeutic behavioral services would be layered on it to address a specific behavioral issue. And then the idea is sort of when that issue has been addressed, then the service is pulled back. And our contractor for that is Stanford Sierra Youth and Families.
Acronym clarification, so STRTP?
Can we go,
Yeah, STRTP.
where does it say that?
Under TBS, placement and
S-
Oh, okay, yes, yeah. Say that one more time?
STRTP.
Oh, so it's a short-term residential therapeutic program, and
Formerly group homes.
we'll get to that in another slide.
Oh.
I'm gonna talk faster. So our juvenile justice behavioral health services provides mental health, family counseling, substance use treatment for up to 50 juvenile justice involved youth under the age of 21. They're community-based rather than facility-based, and pattern on evidence-based or best practice models of treatment, incorporating principles of resiliency and recovery. And these services are informed by probation case plans and often driven by court orders. That's a contract that we have with CommuniCare Olay, and it's limited specifically to youth who are involved with probation in the juvenile justice system. Next slide. Our college partnership program, as we've talked about, is a collaboration with Euclid Community College District with Woodland Community College, and we provide access, linkage, outreach, and direct services for college students. What's interesting about this partnership is that CommuniCare in providing the services doesn't provide just mental health services. They also provide some medical services that's kind of what they bring to the partnership, because they're able to build as a FQHC and to provide those medical services in addition to mental health services. There's some outreach stuff that happens as part of the partnership, and educational services that are provided in terms of like providing outreach and engagement with the college community. And that's with CommuniCare Olay. Next slide. Okay, so the K-12 school partnership program is near and dear to us. It started in 2020. We applied for a grant through the Mental Health Student Services Act. And what we have done is we're braiding funding from the MHSSA grant and Mental Health Service Act. So it's MHSA and MHSSA. Those funds are braided, and we're able to provide services at school locations in all of the 5 school districts and Yolo County Office of Education facilities. And the idea really is to have a behavioral health provider on each campus, but we don't have enough money yet to do something like that, right? So what we have done is we provide services in a regional-based model. We have 4 different what we call catchment areas. So we have Woodland, West Sacramento, Davis, and then the rural areas out in Esparto and Winters. And we have different providers who work directly with the school districts to provide whatever services are needed for that district. Like we know that some of our districts have different assets and different needs, right? So the model looks a little different in each area. It's a tier-based model that aligns. It's called an interconnected systems framework, where our behavioral health approach aligns with the PBIS model that the schools have in place already. And so at tier 1, the services for everyone. It's services for every student. It can look like outreach and engagement. I think you asked earlier.
Training for teachers.
Training for teachers, right?
School assemblies.
Right. Assemblies, like helping teachers to identify potential issues, providing some instruction on maybe how to provide immediate support to students. Tier 2 is more focused, right? When we identified a group of students who may need some specific needs. So for example, in one of our school districts, it was identified that we had an immigrant population that needed some additional support. We had some groups for that particular population.
Or like grief, they did like a grief
Right.
support group because there was quite a few students who had experienced grief themselves.
Right,
Yeah.
exactly. And then tier 3 are for the students having the most intensive needs, and it tends to be like a multidisciplinary model to provide concentrated support for those specific individuals. So it's kind of like the general idea is sort of like tier 1 is for everyone, tier 2 is maybe for more like 20 to 30% of the students, right? And tier 3 is kind of 5 to 10% of the students, like roughly, right? It's not an exact science. And so our providers for that are Communicare and Olay, who provide services in Davis Joint Unified and at Yolo County Office of Education. RISE, who provide services in the rural areas in Esparto and Winters Joint Unified School Districts, and Victor Community Support Services, who provide services in West Sacramento and Washington Unified and for Woodland Joint Unified School District.
And when you provide these services, is there any way that the school districts can pull fund, like if they have certain resources, they don't pull those resources because we now have these resources? Or how do we make sure, does that make sense?
Yeah, so when Tony was talking about this fitting in with their PBIS model, that's a multi-tiered systems of support model, right? And so the schools, luckily, all of our school districts all follow the MTSS model. So they also pool their resources to tier 1, tier 2, and tier 3 services. And so what we've endeavored to do in this project, and I think we've done it mostly, I think there's been some challenges along the way, has been to create a continuum of services that aren't duplicative and that leverage resources the most effective way we can, right? And so when Tony was, I think, being diplomatic when he was saying like it looks different in each district, and that's been because we know that that's the kind of flexibility that we needed to be able to demonstrate and to be successful in this project. So a clear example of that is that we have some districts that are using our project to really build into all of their tiers within their MTSS model. In Woodland, Joint Unified specifically, they have made and invested a lot of their local control dollars to building up their tier 1 and tier 2 services, but where they were lacking or struggling more was in tier 3, so more of that individual therapy. So when we think about the array of services that can be provided, we're talking about therapy, then you're talking about far fewer people to be served, right? But more intense, with more intensity. So Woodland has chosen to, in this partnership, to use these services for only tier 3, pretty much. Maybe some exceptions here or there. And so when we share data around utilization, right, there are only maybe a few dozen clients who have received services in one school district, and in another, they might be reporting that thousands of students received services because they're doing school assemblies where hundreds of students are getting an intervention, or they're doing groups, right? And so it looks quite different.
It's great to hear. It's a true partnership then.
It is
the need of the district, because not every district has the same widget.
That's right.
So I will say we could do a whole,
yeah,
we could do a seminar on just this project. I mean,
It's great to hear.
So one of the things that I want to point out is that there is like a governance model with our superintendents, with our mental health director, right, to kind of steer the project. Then we have an implementation team, right, which is kind of managers, right, in behavioral health and in the districts. And then each region has like a regional committee, right? So each of the catchment areas has a regional committee, and the idea is to engage with community partners. And that's one way that we're informing the services around this. The other piece that I want to add is that
well, when Tony's brain is thinking, maybe it's gonna come back to him, I'll just add that, that our superintendent of schools, Garth Lewis, has been an incredible champion for this project. He's really been the bridge between our system and the school systems. We don't always speak the same language. We learned very early on, right? Which made it difficult sometimes to get on the same page early on in this process. There was some history many years ago around school-based mental health for IEPs and things where school districts had sort of negative experiences with county mental health. So there was a lot to overcome there. But he's been an incredible champion, such a bridge for us to the superintendents. We have some incredible superintendents in our school districts locally who are also real champions for this project and for enhancing mental health services on school campuses. I have to just, and by not acknowledging some superintendents, it doesn't mean they're not great, but there's just some who really stand out. The superintendent of Esparto Unified School District has gone out and sought her own funding to expand access to services through this, sort of shared model to the point where every school campus in the Esparto School District, which is a small number, right? It's a smaller district, but has a therapist on site, which is incredible. That's our goal for this project, right? They're the only district we've been able to sort of bring that to fruition. And that's truly because of their own fundraising, grant writing, and contributions to the project. We just, this past week, finalized an MOU with Davis Joint Unified, where they are leveraging some of their dollars through us to our contractor to now have a wellness center on Harper Junior High's campus in Davis. And so those are real examples of the district either bringing money through the partnership or on their own, and really buying into this partnership model. So we've definitely seen some incredible success. And I think we're seeing that we're starting to see more of that sort of like shared ownership and responsibility in some districts more than others, but certainly it's come a long way and it's been a labor of love for sure. So, and I'm just like Tony's like first day on the job, I'm like, hey, we're going to do this project. And here we are, like 4.5 years later, more than 4.5 years later. And we've done some really incredible things. So it's something to be proud of.
About it, so clearly you guys are really passionate. So
Yeah.
it's great to see it.
The piece I want to address, and I'll try to make it quick, is data and data informing kind of whether the project's working or not. And one of the challenges we were having with this project is that the grant funder and MHSA required different data, right? And so if collecting the data to report out was really challenging. And so we were working with a provider, it's like a business intelligence solution or whatever they call themselves, right? And it's Opeka. And they have a history of working with social service agencies, including with the state, I think, on a specific project. And what we are in the act of putting together, and we believe we'll have it ready probably to start reporting out data soon, is our contractor providers and the school districts can make a closed loop referrals in this ecosystem that they're creating, and it's going to collect data about outcomes, right? And so we're going to be able to get novel data sets that we wouldn't otherwise be able to get. So for example, the goal is for us to find out how did school attendance go with
was school attendance impacted by
was school attendance, what about grades? What about behavior? What about discipline, right? Because they're able to pull data out of the school systems, like out of areas. So they're gonna be able to pull data out of our electronic health record. They're gonna be able to pull data out of our providers' electronic health records. They're gonna be able to pull data out of the schools. And we're gonna be able to have a really robust data set that's gonna inform how well the project's doing. Our hope is that with this data set, it might help us to also seek additional funding, right? Like look at how this is working, right? So again, we could talk about this all day long, but I know we don't, it's night. So we have to move on to the next slide. Because I got more. Okay, short-term residential therapeutic programs. We'll do the crash course and continuum of care reform. Essentially, the state of California and federal government said, we don't want foster youth being served in group homes anymore. That's a bad idea. We want these group homes to provide therapeutic services instead. So we're saying as of 2022, right? Am I getting it wrong? 2021?
Yeah.
I don't know. Basically, there was a forced conversion a few years back, right? Where if you wanted to continue operating, if you were a group home, you wanted to continue operating, you had to apply to become a short-term residential therapeutic program. The idea is to provide intensive behavioral health supports for children that is one step below a psychiatric hospitalization, right? And the idea is that youth who are placed in these settings would receive short-term intensive services and with the idea of stepping them down. The current model is that children are really only supposed to be there for 6 months. They can be there longer, but it requires approval from the child welfare director, right? So they're supposed to check in every 6 months about how the child's doing, and there has to be approval for children to stay there. The current plan is when children discharge, they're supposed to receive high fidelity wraparound services. So it's an additional layer of support upon discharge. We had 2 local STRTPs, both of them closed down. We were having some pretty significant performance issues with one of them.
One moved.
Yeah.
They didn't close, they relocated.
Yeah.
Out of the county.
And we were having pretty significant performance issues with one of them. And we currently have a kind of a unique situation with a specific STRTP in Kern County. And so the situation with that was Kern County has more STRTPs than they need, but there was a provider who was operating there and they needed basically a county to sponsor them essentially, right? Because Kern County wouldn't do it. And we had several youth who were placed there. At the time, we had 4 youth who were placed in that facility. And we agreed to do it. Really, and I gotta be perfectly honest with you, the idea was, we will do this for you because we're kind of going out there, but you will take any of our youth. If we have a youth that needs to be served, you'll take it, because we have a difficult time placing children sometimes in the STRTPs. Again, this is another topic I could go on a little bit too long about, but I just want to make it clear that we do have a contractual relationship with one specific STRT, but it's down in Kern County. We have the ability to contract with other STRTPs, and the state actually was mandating it through AB 1051, which is a topic I don't want to get into either, because I got a lot to say about that. All that to say, when it comes to STRTPs, our goal has been to reduce the number of children in STRTPs to 0, which is a benchmark that we finally achieved last month for the first time ever in Yolo County, and I mean ever, right? If you look at the data set, it goes back into the 90s and had never been at 0.
And I think at the highest, there was over 50 youth
Right.
in congregate care in Yolo
Right.
County. That's a combination of
Right.
probation and child welfare. So
Right.
to have 0 is an incredible
We had a good run for 16 days. We currently have 2 youth in STRTP.
But even that is incredible, right? The vision of CCR was to reduce the
Right,
reliance on
100%.
congregate care. Children were languishing in group homes for many, many years in the foster care system without really getting the treatment that they needed, and in fact, getting worse usually in those settings. And so I think that the vision of CCR has truly been realized here in Yolo County. And every county can't say that. If you read the news, you'll see there are some counties that are in the hot seat a lot for not having placements for youth, housing them inappropriately, all sorts of things, right? And so the work that has been done here is something to really celebrate.
So a question, so how are the contracted providers, so I see there's only one right now, but how are they evaluated? And is there?
Well, so
kind of like
placements in
evaluation?
STRTP are actually made on a youth by youth basis. So while we have this agreement with Brighter Horizons, we place when we have a youth in our foster care system or in the probation system who needs placement in an STRTP, we are placing them in an STRTP based on their individual needs. And so there are some programs that have specialization, like there are STRTPs that specialize in serving youth who have been commercially sexually exploited, or there are some facilities that specialize in treating girls, or there are some programs that specialize in treating sex offenders, right? I mean, there's some specialization. And so while this is our one contracted provider that we hold the agreement for, we will place children in facilities based on the fit, because this might not be the right fit for everyone.
Okay, yeah,
Yeah.
my concern was just like, how are these programs evaluated before sending children out of the county to them,
So-
especially if it's all the way in a county that's pretty distant, that might be a little bit, because of the separation, might be a little bit harder for people to evaluate, especially if it's a private facility as well.
So that's why we don't want to do it. I mean, I'll be perfectly honest with you, right? When we had the facilities in Yolo County, you're kind of blackmailed by the state, right? I don't know, that's probably not the right word, but like you're forced by the state to work with them, right? The problem is, we could say, oh, okay, we have a need for this placement type for our local youth, but it's not a local resource, it's a state resource, right? So once an SCRTP establishes in Yolo County, they can place youth from all over the state. So we can have a youth that needs to be placed, and there may not be a bed. Also, private providers place in STRTPs, and private providers currently are actually taking up over half of the beds in STRTPs across the state of California. So there's a bit of an equity issue as well, because we have foster youth who are sleeping in offices in certain counties that are making the news, right? When I've got a lot of feelings about this that we probably shouldn't get into here, but let me just say that what you're describing is exactly why we don't want to place youth there. And so with Brighter Horizons, our program manager, Dr. Mary Young, our compliance officer, went down to the facility to do like Medi-Cal site certification, and we have high confidence. Our social workers, when we've had children there, they go there at least once a month. When we have children in STRTPs, there's a lot of kind of eyes on the situation. They meet at least once monthly in a multidisciplinary team. It's like child welfare, probation, behavioral health. We have our court-appointed special advocates program. We have both of our wraparound providers who participate in it, the California Regional Center. And it's a multidisciplinary meeting where we're talking about how the youth is doing in that facility. Are they making progress? Are we making a plan for them to step down? Locally, we want to do everything we can to get kids out of these settings, right? Because what we have seen is that some individual results may vary wildly, right? And that we have had children that we place in far away locations who do not do well, right?
And those placements are made, by child welfare probation, not by the mental health plan. So I just want to be clear that.
Sorry, when I say we, I mean.
He's the child welfare director.
Right, yeah. So anyhow, we don't want to send kids there.
Okay, yeah, because I know there's some concerns with the impact of long-term institutionalization, especially for youth, it being like developmentally appropriate, and also like people getting an institutionalized mindset instead of like being able to function in society, which is the goal. So
we do everything in our power to make sure that children are not there for a very long time. We had some children who were definitely institutionalized, right? And it was a lot of work to step them down from this level of care. We had a particular youth who had been in this level of care for like far too long, right? I mean, we've had some very tragic cases from kind of a previous way of doing this work, right? And we've done, I feel like, a good job of like our youth who are currently in SCRTP. It's like we have no other choice, right?
It's the
and we're actively trying to step them down again, right? Again, happy to take these conversations offline.
So I have a question, just in terms of like time check. Everyone seems really interested and engaged and wanting to ask questions. So I want to make sure that we don't like shortcut the ability to do that. And maybe we need to move some of this to another meeting, because I think it's important. and people have good questions.
I'm almost done. I'll race through the next couple slides so Carlin can get to
But
this
that's
stuff.
I think
the
that's what
thing,
you're
I just
saying.
want to
So-
make
I think
sure
she's
I'm not
saying-
like
Oh, okay.
rushing
Okay,
through, because
okay.
there are good questions and people are really engaged.
Got it,
And
okay,
so I just want to make sure,
We could also move to expand.
yeah, that's true too.
I don't know how people feel about that.
What? I couldn't hear you.
Oh, sorry, we can move to extend the meeting if you want to stay like an extra half hour or something like that.
What about?
I don't know. But does
Sorry.
you get-
It's fine, I guess.
I'll call my mom. I'm saying at your house.
I mean, yeah, how much longer do you think you have?
Not much longer.
Okay. Let's just maybe have you go through, and then, because I think what Tony, so, I mean, just, I think Tony's mindset coming into this was that there's gonna be a lot of information here, and that hopefully, which I think all of our dreams are coming true, because you guys love this, and this is wonderful. It's really nice to have everyone engaged talking about children, you know, it warms our children's
100%.
hearts, right?
Yes.
That maybe some topics would sort of rise to the top around things that you want to know more about, that you'd want us to come back, you know, Tony or a panel of folks to come back. Like if the K through 12 project is of interest, we could bring back a panel that includes some of our providers or our school partners. Or if you want to know, you know, whatever. So maybe he can go through the rest of the slides. Maybe we can have some conversation about what maybe we can come back with more at a later time. And certainly, obviously, after consulting with our chair, who's not here.
Didn't you say we were gonna get a copy of the presentation? so
100%,
we could
yeah.
actually
We'll
look at it
send
and
it-
then
we will
come back
send
with
it out.
questions?
Yep.
Okay,
Okay,
next
next.
slide.
Okay, the Family Emergency Response Services, the quick highlight about this is that this is a program that the state requires us to have in place. It's a statewide system that serves current and former foster youth up to the age of 21, again, you know, up to their 21st birthday. So,
And this is a social services delivery funded program.
but we work with one of our behavioral
Yes,
health
which is-
contractors, right? To provide the services, right? And so, essentially, the way it works is that if a current or former foster child or their caregiver, if there's an urgent need, then they can call a state hotline, they'll get some crisis counseling, and then a decision will be made about whether or not to dispatch a mobile team. So we have a local mobile team that can be dispatched. They can provide services really the idea is to preserve placement, and then they can provide follow-up for 30 days afterwards, right? So many of our behavioral health clients also can receive this level of service. The idea really is to not involve law enforcement whenever possible, right? And to keep foster children in stable placements, or if they're former foster children, right, to keep them stable wherever they're at. Next slide. Oh, and Victor Community Support Services is our provider for that. They've been doing it since the beginning. The EDAP program is the program through UC Davis. That's the early psychosis program. It includes the EDAP clinic. The EDAP clinic provides coordinated specialty care in an outpatient setting that incorporates medication management, individual, family, and group, psychosocial interventions, case management, supported education, and employment with the goals of diagnostic, treatment, and disability prevention. They provide screening, assessment, and a full array of EDAP services to Yolo County youth and young adults who are experiencing severe health challenges, including early symptoms of psychosis. And as mentioned earlier, the age range for that program is 13 to 30. And our contract provider is UC Davis. We have an array of substance use disorder services for youth now, as of this year, through Communicare Olay locally. That provides outpatient and intensive outpatient services, and children and families who are seeking to access these services would go through our 24/7 access and crisis line. They indicate that they're seeking substance use disorder services. We also have a quasi-relationship with Tarzana Treatment Centers in Southern California for inpatient SUD services for youth. We do not have a contract with Tarzana because they won't contract with anybody but LA County, right? So we have like an MOU with them that says that if we have a youth who needs that level of service, that we can do a single case agreement with them. That's as much as they're willing to partner with us on.
And youth is described age-wise as?
Under 18, I think.
Yeah,
for this.
yeah.
This
For
is
this,
different than
this is
specialty mental
different than
drug
special
mental,
needs.
yeah.
Okay.
Yeah, so it's you.
0 to
0 to 17, yes.
Okay.
And again, so our providers are Communicare and then Tarzana on a case-by-case basis. And this slide was really, I planned to have a little bit of a chat about Alta California Regional Service, Alta California Regional Center. And just the high-level overview is that, again, these are services for, they're not behavioral health services through us or they're one of our partners in the community, but they provide services for developmentally delayed children and adults with a developmental delay that was diagnosed with an onset prior to age 18. And they can provide an array of services. And so sometimes when we're coordinating with an individual who has dual diagnosis, we'll work with the regional center to see if the regional center can access services that are more appropriate. One thing that is really important to remember about the regional center is that the Landerman Act contains a mandate to only serve individuals with developmental disabilities, but also to not provide duplicative services that any member of the community could access, right? So it's not their responsibility to provide a service if any other member of the community could access it a different way. And so when we're working with the regional center, we always have to keep that in mind, right? There are some services that they're able to provide that we don't actually have access to, so like applied behavioral analysis and things like that. And I just want to put this here because they provide some different services for some of the youth that we work with. But that's not us, that's a different entity. Okay, next slide. Just real quick, I know that there was a request for data. There is obviously lots and lots of data that we could get to. And again, the idea here was to provide just a broad overview of the local system of care and again, an idea about what you might want to learn more about in the future. And with you will be provided with this. So we had 971 referrals that were made for specialty mental health services in fiscal year 23-24. In that last fiscal year, we served an average of 365 children each month through our internal providers and across our contracted system of care. So we serve about 365 children a month last year. The average length of services that individuals received was about 12 months of services. We served over 3,000 students in all of the districts through the K-12 school partnership. And as Carlene identified earlier, like, you know, it's an array of services, and some districts may have received more than other. More than 90% of the youth receiving intensive services, so that'd be a wraparound, full service partnership and TBS. More than 90% of those youth remained in home-based placements without psychiatric hospitalization or juvenile detention. So that's a measure of success for those programs and how well they're doing. 167 children and youth did experience a psychiatric hospitalization, but our internal team provides discharge planning. Real quick, I want to talk about something that our internal team does that didn't happen before. We were having youth who were ending up in emergency rooms, and they'd be there for days at a time sometimes. And sometimes they didn't know that they were our clients, right? And so we meet with them on a regular basis now. So we meet with the local emergency departments. And so we have this really much better coordination between the emergency departments and all of the different hospitals when there's discharge planning. We have an individual who does that discharge planning in coordination with the hospitals now, so that we don't have children sitting there as long anymore, and they have effective discharge plans.
Does that include adults as well?
Huh?
Does that include adults as well?
That's in the children's system.
I mean,
The adult has
I'm just curious.
the adult system has their own.
And those are hospitals outside of the county as well.
Yeah, these would be psychiatric hospitals. So we work closely with the emergency departments so it's a Sutter and Woodland. We work closely with them, but when we have youth that are in psychiatric hospitals outside of the county, right? Because I don't know of any psychiatric hospitals in Yolo County, right?
Oh, no.
Other than the
no.
emergency departments, then we
Just
work on the
the
discharge money, yeah.
Yeah, it's just that there's pediatric ERs that are not in Yolo County.
Pediatric what?
ERs,
Yeah.
Oh, okay, yeah.
And so-
Yeah, but it's coordination for any Yolo County dependent.
no matter where they are.
Well, so let me back up just a little. We currently work specifically with the local emergency
Got it,
room,
okay.
right? If we are aware of one of our Yolo County youth that is in another setting, then of course we do. And we're alerted when Yolo County youth go to a psychiatric hospitalization. And so we'll start working with the hospital on discharge planning, making sure that if they're not already in our system of care, that we can connect them to one of our providers when they do discharge.
So do we have a graph of, say, maybe over 5 years, what this looks like?
I mean, I'm sure we can put one together. I don't currently have one, no, yeah.
Okay.
Yeah, but we could, if that's something that the board's interested in, we could certainly do that.
Can you stretch it back a little bit earlier, actually, like 10 years or something? I don't know if that's doable.
I'm pretty sure we can do that.
Okay.
Oh, that'd be great.
We will
For some
make-
of it, yeah.
Yeah, we
not all of it.
will make our best effort, you know, and basically I'll report back if we're having problems with it, but we will do our best effort to give you some historical trends.
Thank you.
Okay,
Like clarifying question to make sure I understand, so then does this encompass all kids that go through psychiatric hospitalization within Yolo County, or just kids that are Medi-Cal beneficiaries who are Yolo County clients? I don't know if that makes sense.
Yeah,
Right.
we're the mental health plan for Medi-Cal,
right.
right? So our responsibility is to Medi-Cal beneficiaries. Now, I mean, the answer I don't know is if there's any coordination for private.
I did not, we would not be doing coordination for private insurers.
So it's not every candidate, yeah.
So like, for example, when we have our meetings with the local emergency rooms, we talk about Medi-Cal beneficiaries who are there. So they have privately, and they have youth who have private insurers who we're not able to talk to them about those kids, right? Because of HIPAA, right? They're not able to even disclose to us that those kids were there.
So in the stats we're seeing on the slide, this only is Medi-Cal beneficiaries.
Yes.
The stats for the psychiatric hospitalization, right? Now for the 3,000 students served in all districts through the K-12 school partnership, that could be, that's independent of insurance type because that funding source doesn't require us to.
Yeah, but for psychiatric hospitalizations,
Medi-Cal
that's
beneficiaries.
specific to Medi-Cal.
And it's impossible to get the data on.
Yeah, that's
We
what our.
we currently don't have a way to obtain data on non-Medi-Cal beneficiaries. We would have to work with the.
Well,
Well,
hold on. There's some new legislation that just went into effect that requires county mental health director, myself, to enter data into a system that reports out on 5150s.
Okay.
And so we will, over time, have that data, because that data is provided regardless of insurance. I actually don't know the insurance status of the folks that are being reported in that data. We're also working to ensure that every entity that is writing 5150s is actually reporting that data to us, so it's a work in progress. So, I mean, to answer that question, I think somewhere in the future, maybe within the year, we would be able to share some data around at least 5150 holds, around longer holds, around subsequent hold, right? Because those are some of the data points that are being reported there, and they're reported for children and adults. So I'd be happy to bring that data here, and just with the caveat that right now it's imperfect, we know that, and that I wouldn't have any context to the data, right? Because it's coming from multiple sources. But I think over time that will, and especially as it starts to improve, the reporting capability from each of our required entities that need to report, then that will be able to give us a picture over time. Now, we don't have that data going backwards, but we'll have it moving forward.
I mean, is there any way that EMS or EMS partners at least partner with Davis and Dignity to at least look at wall time? So if there's holding kids that are not Medi-Cal beneficiaries, but there should be some data with wall time or kids' hold times. So I'm
Yeah, I don't
curious if there's
know.
a way to access data that way.
I mean, maybe, though it would still be a a not complete data set, right? Because EMS isn't only the one with wall time, right? Could be law enforcement.
Or just even hospitals that are holding, how long they're holding in their ERs, because they have to report that into the county.
Yeah, I mean,
So.
yeah, I mean, I'd be open to exploring. I mean, I think there's a lot more we could be doing in terms of data sharing with our hospital systems, and, you know, it's limited. We don't have a mechanism for that right now. You know, we don't even have a sort of regular cadence of like a convening of the right folks to be talking about those kinds of things. So those are all things I think we're interested in, you know, and looking at some of that. And they certainly have that data, right?
They
But
do. That's why I was just
yeah.
curious if, I know there's a group, I remember a different county group that has all the ER
Yeah.
directors there.
Yeah, and I think Sam's listening, and so she's texting me. She's, yeah, I think she's saying we absolutely could get the wall time data from the ED, from their perspective, you know?
And then their full times as well.
Yeah, but that, I mean, and I'll just acknowledge that also goes beyond our,
It does, but it also
Response,
have adults, and that impacts understand adults too, the ones that are not covered under county.
Yeah, because I think this kind of highlights a data hole in terms of
Yes.
if people have private insurance but are interfacing with public agencies to get put in a hold, then there is that, it kind of, I guess, like messy data in terms of, well, they're being counted under like private insurance one way, but under like public services another way. And then kind of how do you evaluate efficiency in that case? Like,
yeah, I mean, it's an imperfect
Yeah.
system, right? And I think it's one where we don't have access to all of the, right? I mean, I think that, I think people have higher expectations for what county mental health is capable of than what we actually are, you know? I mean, I think it feels like we're responsible for all of the mental health of all of the county, you know? And so I think there's a lot of opportunity to strengthen. Commercial insurance is a black hole for us, I'll just be honest.
And honestly, a lot of what I hear are parents struggle with the commercial insurance.
So,
It's not necessarily the kids who have the wraparound services.
so speaking to that, and this is my last slide, but the next one is like, do you have any questions? Just speaking to the point that you just made, in our K-12 school partnership project, the idea was for us to leverage the two different funding sources and to create sustainability by drawing down funding through Medi-Cal billing, right? That was the model that we proposed at the beginning. However, our partners with the districts were like, well, wait a minute, you're saying we can only serve kids that have Medi-Cal? I'm like, no, we can serve any student, right? But we want to serve kids with Medi-Cal because we can draw down funding for those kids. And what we found overwhelmingly was that the districts wanted to refer the kids with private insurance. Right? That our assumptions about the amount of funding that we could draw down through Medi-Cal billing, we were way off, right? Because the districts want us to serve the kids with private insurance because of exactly what you're saying. The parents are like, I can't get services for my kid, right? So in many ways, we're providing, we're providing like a supplement, right? For private insurers, right?
But you're putting the child first, so thank you.
We are, but I mean, the reality of it is that the funding for these kinds of projects, it is very tenuous, right?
It's not a sustainable model.
It's not a sustainable model, right? And so, I mean, there is some kind of like light at the end of the tunnel in some ways, right? Because now there's the legislation that has created the opportunity for districts to bill for bill for behavioral health services that they provide to any student regardless of insurance type. It's called the multiple fee schedule. And we could talk a lot about that too, right? But it's going to require like a tremendous amount of coordination between HHSA and the districts, right? And require all kinds of braided funding, right? And so we're looking at a bunch of different things currently around that. Again, I could talk all day about different stuff, but I know we need to get on with things, so I'll let you do your thing.
Oh, no, this was great information.
Yeah.
I would encourage everyone, once the presentation becomes available, to relook at it, because we may have additional questions that help us define like our follow-up items from this, because I do think there's going to be a few
I imagine.
based on the questions today.
Maria, in terms of time, can I just start and just kind of next steps, kind of make a suggestion? So I worry that my topic would open a can of worms of questions that could go on for a while. And I want to honor, I also just am sensitive to the fact that Christina's an hourly employee, you know what I mean? Like so I want to, I know that we weren't off schedule, and I just want to respect time and just distance, right, of driving and things like that.
Right.
And so I know there's no meeting typically in November. Christine and I were just sort of sidebarring here that, and just to be transparent, it is likely that I'm going to ask the chair to schedule a special meeting in November because we have the MHSA annual update that we'll need to present.
Okay.
If the board wants an overview of it before, like while the public comment is open, before you just hold the public hearing. So if that's the case and you want a preview of it, then we will need to hold a special meeting. I'm happy to take what I was going to do in a presentation and write up more of I was very sick last week. And so really, so yeah, it actually until Monday. And so I'm better. I'm just, but I was very sick. And so, I'm happy to actually write that up into more of a report that I can then share. I don't have it in a written format. I mean, I have a PowerPoint, but it needs context. And so I'm happy to write something up that I can share with the board, because really it was just a temperature check and just a bit of sharing to look back on how our actual revenues have differed from our projected revenues and how that's impacted fund balance, and as we look ahead to the MHSA plan. So I was just trying to set the tone for that. I'm happy to do that and get it to you within the next 48 hours or so, if that's okay with the board. That way you can move on with the rest of the agenda items, and then I can talk with our chair and our executive committee about potentially a special meeting then to review the actual plan. I don't have the plan to share today.
Should we just go ahead and vote for a special
That's
meeting?
So can I just, the problem is that I don't think you can actually take action if there isn't an item on the agenda. I think it's a Brown Act issue.
Okay.
And so unfortunately, as much as I would love for you to make a motion to hold a special meeting, I think that there's a Brown Act issue here.
Okay.
And
I think
so,
we also have to provide public notice.
yeah, and so I
Yes.
don't know that, yeah. So I can reach out to Jonathan to kind of let him know this is what we talked about and that I'm asking for this. And we can perhaps even consult with county council on how we can navigate it to get there, right? Because we have this sort of gap, right, with not having a scheduled meeting in November. And
Is there any chance that county council will say, no, you would have had to go to this meeting? I'm just wondering if we should vote and maybe it will take effect.
The only way you can take action is if there was an item on the agenda for it.
Right.
So I think that's the Brown Act issue.
It's just that in that case, it seems weird that the executive,
that
you would be able to just make it up,
Yeah. I don't know the solution here, but I do know that you can't vote on something that isn't an action item on your agenda.
Can we check with our availability, say, for example, November 6th, which would be the first Wednesday, if everyone might be available in case the executive committee decides to call.
Or
a
figures
special-
out some way, because I don't know if there's any way to.
I don't believe there's any restrictions to calling a special meeting, and we would just have to notice it to the public 72 hours in advance. So it doesn't have to be voted on. You can just state that the local mental health board is meeting special.
If we were to look at our calendars and kind of say that November 6th, if they were gonna call a special meeting, might work.
That's fine.
Yeah.
First Wednesday?
Be the first Wednesday.
So let's just ask about calling on a different day.
So I guess everyone here is to, if it were to be called for November 6th, we would be here.
Thank you so much, that's very helpful. Thank you.
And then I guess we would table that.
Do we need a motion to table the MHSA update and the mental health director's report?
I would make that motion to table it for a special meeting if it were called.
And like I said, I will provide you guys something in the next 48 hours or so, just to give a summary of what I was going to share tonight.
Okay.
I second the motion.
All in favor?
Aye.
Any opposed? Any abstentions? Oh, Nikki has her hand up. Are you
She's
abstaining? Or
Oh,
agree?
no, it was just, I was trying to vote yes, but I was a little slow. on
Thanks,
the-
Nikki. I just want to make sure I'm not missing you.
And I don't know if you were going to take public comment for Tony's presentation.
Yes, it's coming up.
Okay.
We have it on the agenda.
Okay.
But we can move it up. Does anyone have public comment on Tony's presentation or the items? Is it Christy?
It's Christie's.
Christy?
Oh, hi. it wasn't specifically on Tony's presentation, but I thought it was very, very well done and very informative. I learned a lot. I wanted to make the comment that I would love to see the MHSA update maybe posted to the website, either the MHSA Yolo County website or the local mental health board's website, somewhere where the public can access it prior even to the special meeting in November. So that was it. Thanks.
Thanks, Christy. Yeah, we'll make sure that there's plenty of notice for people to review before the meeting.
Thank you for the comment.
Sorry. Is it, the slide, is it available to the public also?
I don't have any objection to sharing it with the public.
Okay.
It will be available on the website.
Yeah, it'll be posted on the website.
I'll share that with you at the end also.
And I appreciate it was very informative, like you said, it was very informative. And one of the things that I wanted to say, I had a question that I didn't know if I could ask it in this setting, about the transitional age youth. One of the barriers that we face as a service provider is that we have had a client who was 17 years old who was in the transitional age youth program that we were in. And one of the things was that the psychiatrist refused to see that person because they were underage, but they were a part of our program. So it was like we were stuck. We couldn't help that client get the care that she needed because the psychiatrists have different guidelines or, people that they have to answer to. And I didn't know if that was something that you guys were aware of or how, or maybe to bring to your awareness that that's an issue that we face.
Do you want us to respond to that? I'm happy to have a conversation with you after the meeting if you'd like. I believe that we're not allowed to respond to public comment.
Got it.
Okay. All right, thank you.
Thank you.
I did read the Brown Act guidelines and a special meeting can be called at any time. It just has to be noticed 24 hours in advance and that's it.
So it can just be the chair who calls it?
Yep.
Okay.
Oh, there's another public comment. Oh, yes.
It's related to something that Chris Volpe brought up to Tony during the meeting. So I know that Tony can only speak to some things regarding that. I know that he was the supervisor of the transitional age youth program when it was discontinued. I was a staff person at that time. I'm also a former TAE client. So if after the meeting people had questions regarding staff experience of that, I'd be happy to speak to that. Obviously, that's more just informal, but that seemed the only appropriate way to bring out that. So thank you.
Okay, so I think we have a Board of Supervisors report, correct? Chris, do you have an update for?
Well, I got a whole bunch of stuff, so I'll try and be brief. We will have 4 graduations in October. I will get that information to get out. Sometimes the location moves depending on the judge's availability, which can be frustrating. And that's the good news. Bad news, on September 16th, we sentenced 3 people to prison who failed our specialty court programs. So not everyone graduates. We were able to keep 2 of the people in the Yolo County Jail so they could be assessed by HSA staff and try and coordinate the FSP level services so when they got out of custody, they would have services. So I think that's going to put a positive spin on that. We have a hold on referrals to our mental health court and addiction intervention court until December. They've been on hold since late July due to staffing issues. And probation, it's a team effort, so that all the departments have to be able to sufficiently staff the program. So we're on hold till December. Our numbers are 21 people on health court. We're supposed to have a capacity of 30. We have 26 in AIC. The Department of State Hospitals diversion program has 7 people. We just graduated 2 people on Monday. And so the statewide average for success is 60%. We've had 12 graduate and 2 failures, so that's well above. And that is a HSA staff program. We have people that were getting assessed to go into that program. Our mental health diversion program Has 25 people in it, with 4 that will likely go in once their case is resolved in the next couple of weeks. One of the reasons I brought up the opioid coalition is that we've had 3 overdose deaths in our specialty court programs of recent graduates. And so it's a challenge with fentanyl. And we will become a behavioral health board next year, so we need to be aware that a lot of the people that are seriously mentally ill have co-occurring disorders that also deal with addiction. And so it's a challenge. We have lengthy wait times in custody for people to go into residential treatment because we're down to 1 residential treatment provider. When we first started the drug medical program, there were 3. I know that the county's working to expand that. That's kind of where we're at right now with that. We have been successful with some conservatorships with a well path recommends that. And so that's a positive note. Instead of incarcerating individuals, we've been able to transition them out of the jail into a conservatorship. So that's a positive. And we're working on more of those as we try and have that linkage from in custody to services in the community. And the MDIC was mentioned earlier. If people, it's not really a mental health thing, but I'm sure we can get a tour if people actually want to see what that is. I can explain what that is offline.
We do have a clinician embedded there, so, we have a children's clinician embedded there full time, so, yeah.
I know, I just don't, we're late, I don't want to go
Yeah,
into it. Here's what the
Yeah, but I mean,
MDIC
it's a
is.
mental health thing
If you
for
have
us,
questions
yeah.
about that, I can sort of explain that process offline. And that kind of sums up my report.
Thank you. I think, part of what happens in these meetings is we kind of scratch the surface and there's so much to want to know about and actually have some plan around recommendations. But I think probably, Christina, like if we had like a running list and then this group could kind of look at it, I think it would help us decide what kind of things we want to put on the agenda in the future. Because you've brought up some good points too, that would be worthwhile learning more about.
Maria, just if I may make a suggestion, it might be helpful to this body to put an agenda item at the end of each meeting. Like, is there anything we heard tonight that we want to know more about?
That's a good idea.
Or that we'd like to follow up on? Because I think that would help trigger for Christina a running list that should be key for you, because I think a lot of things are thrown out in the meeting. I don't think she would necessarily know what stuck for you, so maybe there could be just a bit of a round table at the end. It might be a nice way, because, and it's not just always based on, the presentations. It could be based on public comment. It could be, based on correspondence that came in or something like that. So, I know there's a future meeting planning and adjourn, but maybe a specific prompt of like, I don't know, like just a quick roundtable, right? If there's something that stood out for folks that night.
I think that's a really good idea. You guys open to that? Meg, you wanna?
Do we need to vote on that or just?
Or do we?
I think it's just around the agenda structure. I mean, I think it's hard without the chair here tonight. So, perhaps some of the follow-up is just to sort of share some of the feedback from tonight, and then that can help inform an agenda setting for future meetings.
Or presentations, somebody that you want to have come in.
Absolutely.
Presentation. I think Nikki talked about that before.
Yeah. I think while it's fresh in our mind, we could just put it out there. If we need to make a motion, we can make, but it's not on the agenda.
Yeah, you can't take action on anything tonight.
I think because we have a section that does discuss future meeting planning, it could just be, as
A
long as
bullet
it's
point
clear
in
to
there,
me,
yeah.
Christina, we need to have a follow-up for this, and I'll note it under the future meeting planning.
I'm actually hopefully gonna, Nikki, can you hear me?
She here?
Yes, I can, but you couldn't hear me because I was muted.
I wanted to call on you first in case you had any items from today that you want to put on this list. I don't want to miss you.
I'm really interested in a little bit more detail about who decides whether a youth is in the transitional age youth program or in the adult program. I'm not clear about how the handoff happens because, and this is very critical because the age of a first break for many of our clients is right at transitional stage.
Great, thank you. Nick, is there any item?
I mean, I think, going through it, I think that would be great.
And I'd like to have further discussion of the MDIC tour.
Okay.
And then we gonna have an update?
Well, do you want me to give a report? We did a site visit.
Oh, yes. What's on here? Did I miss that?
Look forward to that.
Should we table it to next? Yeah.
I don't know, do you want
Because
it?
it's pretty extensive.
Yeah, and, oh, then I don't want to rush through it.
Okay.
Is that okay with you?
That's fine, we can do that next time too, or the next meeting.
Yeah, we went and we filled out.
Yeah,
We did.
I think Christy's probably very happy to hear that the first site visit happened, so I'm glad she's here to hear that.
Yes.
Woohoo, good job, Kay.
Yeah, we did. We filled out the forms.
You guys
We
rock.
got a client interview
Yeah, we
too.
got a client review, it was great.
Yeah.
They're
Very good.
For us to just have access to the form, if you might be helpful to read it before you present, so if you have questions.
Yes.
Yeah, we can provide.
I can give a copy to Christina.
And I can upload it.
Yeah. I can just email it to you if you want. Okay.
Good job, Sarah.
Yes.
Nothing
You want to do that before we send? Which one are you on right now? Okay. She's gonna add to mine and then we'll send it to you.
And I'll share it.
To the next one. 'Cause she's gonna do the final. Oh, you still, okay. Let me see where.
Yeah, there's nothing.
Is it on there?
Except to say that we're going to have them to, I guess, we send them.
Is it on the top? On the back?
We didn't do the ad hoc committee reports,
Okay.
but it's like a 3-word report for each.
I need to put my glasses back on. Okay, go ahead and do the bylaws.
We'll have it in December.
Yeah.
That's our report.
Well, the code changes from behavioral health board, and that changes some of the terminology in the bylaws. And I believe it also changes the membership structure. And so we need to make changes that reflect the change in the law that goes into effect January 1st.
And we will have those in December.
I suppose maybe we just want to have a draft available for review in November if we have a special meeting.
Okay.
I don't know. We'll talk about it.
I don't know how special this special meeting is. Are we just using the special meeting for the?
I don't think it would take the whole meeting, but I mean, after tonight, you know. No, I mean, I certainly think there could be room for action items, yeah.
I'll be more careful about my questions.
I mean, it was.
I think you can definitely talk that way you can speak about it. It's-
Yes.
Yeah, that sounds
Right. Okay, so sorry, I crossed this out because I didn't put my glasses on, and that's how come I missed it, so I apologize. So then, Kimberly, was there anything about tonight that you would want to put on, like a waiting list for items to follow up on or to hear more about?
I guess, even though it was already gone over pretty extensively in terms of like the presentation of the local children's system of care, it might be helpful to have resources provided where we could find out more about that on our own for just us to get a better understanding individually.
And then we were gonna talk about our next site visit. I know I didn't make it to this one, but I wanna go to the next one, so
Yeah.
we can talk about that.
That's what I
Choose
would
another
like,
site.
we need to talk about that, yes.
Okay. So site visits for sure. Called out specifically under the ad hocs.
And we'll have our report by then too.
Exciting, good job, guys. Did you have anything else?
No, I don't.
Okay. Brad, you follow this? I don't actually. I won't think about it though. John?
We didn't really get to emergency responses for
Yeah,
children
about this
tonight,
report.
so
The crisis?
Yeah, exactly,
Yeah.
yeah, so if we could follow up with that, that'd be good.
Are we talking about this report specifically that we just went over today?
Or just, I thought it was in general.
Or we-
Misunderstood.
Or in general, what we would like to
I
hear?
don't know. That's up to you guys.
Because
I was just
Well,
suggesting, I mean,
Yeah,
just,
I think it's a roundtable of kind of what we talked about today. If there are items though, maybe, I guess email Christina and we can talk about it later.
I think, it's a way to sort of, for her to have some more specific notes that then the executive committee can be looking at when they're setting the agenda for the next meeting, or, as you all are looking at long-range planning, so.
But like an alibi, I did mention drug treatment,
Yep.
already, I didn't want to repeat myself, so if that's already
Yeah.
not on there.
If it
The
could,
opioid issues, the drug issues in the
I
county.
agree.
Well, I think residential treatments, I mean, I know a lot are closing, and so I'm curious too.
didn't you mention that a program that you were announcing for us to, if we were interested in joining?
Oh, I could arrange a tour of the NJIC facility if people
What
want
about
to see it.
a presentation? Would that be something useful
On which topic?
on the one you were just talking about, the opioids and?
I think it would, because I think that, everyone here needs to understand how the drug Medi-Cal works, how what the treatment challenges are, we do have overdose deaths and I think there's increases in that. What are the drugs that we're seeing in the county?
Which you just shared with us, 3 people.
Right.
Not all the same, I'm not gonna go into what there's, but I think that there's a tragedy that is occurring in the county, statewide, across the country that we need to be aware of on this board as our duties have evolved with the change in the law.
So we could have a presentation, have somebody come in and do that for us.
There's a number of different things we could look at in
Yeah.
that, but,
Sounds good to me.
I think the other thing on that is I wasn't aware of that. You have folks who have loved ones with pure mental health, they consider like their loved ones aren't self-medicating or don't have co-occurring, and they're very concerned about it becoming the Behavioral Health Act. And so I was not aware of some of that, feelings out there in the community. And so I think as we are more aware, it will help us if we ever, we can speak to it, because I was kind of blown away by some of the feedback I've gotten in some of my groups.
but the change.
Yeah, they're not, people are concerned that resources are gonna be diverted. And so I think for us to understand, that's probably not the case, but what does it look like?
What resources are being diverted with the change to the MHSA?
That's what people voted for in Prop 1, so,
Yeah,
for the resources to be
yeah,
diverted, so. that's
They're
exactly
being
what's
diverted, but there's less resources because the
Okay,
state's taking
yes.
10% as opposed to the 5% they took before.
Right.
And I think that
Well, you said it much nicer than people. So I think, yeah.
I'm broadcasting out to Yolo County as a appointed person on a county board.
Yeah.
We're
No,
in a
I
hallway.
think it's something I was not prepared to speak to, and I'm not, I'm just helped to educate, but I think for us to understand what does this mean for us as board and how are we prepared to change our lives.
We may get some of that, we have a special meeting. What the changes are, what the challenges are gonna be, 'cause there are a lot of those.
Right.
Um,
So that would probably be an item on that list, Christina.
Yeah.
Big resemblance. Okay, I think, did I get everything now? Just want to make sure. So we have proposed a potential date for Jonathan to consider for the first Wednesday in November, if we need a special meeting. And we'll talk to him about it. We have our list. Anything else? Okay.
Thanks for sharing tonight, really.
Thanks, Maria.
Thank you for the presentation. I have to go by, Lori's office to drop off
Oh,
the paper.
do we need a motion to adjourn?
Wandering through the building. I need to drop off this paper on Lori's office.
We don't need a motion.
Yeah.
The thing I saw is that they don't have a gavel. And there's a gavel.
Your numbers.
There, that
There.